Our current state, as far as our preparation and management of COVID-19, is we're probably a couple of weeks behind New York City. We continue to watch. We actually started our preparations watching what was happening in China, Italy, Seattle, and now New York. So the good news is we're learning from other people's experiences as we decide the best way for us to prepare. Over the last week or two, we've seen a steady increase in diagnosed cases here in Massachusetts. Interestingly, across our health system, we have two community hospitals in addition to Tufts Medical Center. So Lowell General and Melrose Wakefield have started to see uptick in their positive diagnoses, confirmed diagnoses of COVID a little more quickly than us. And I think that's kind of an interesting trend where community hospitals might see the surge going into their organizations before it comes into the city-based medical center, academic medical center like us. So we started our preparations in January with really three goals that kind of came to the forefront by, I don't know, maybe mid-February, where we started to think about really three strategic priorities for the medical center. One of which was managing capacity, knowing that if a surge were to occur, capacity was going to be a critical asset. We also talked about slowing the spread and what it is that we could be thinking about around social distancing. And then the third was conservation of PPE. And so those three strategies were somewhat medical center wide, and we could then internalize those strategies into our preparations as a department, continuing to plug back into the incident command center's cadence of daily meetings. And so from a Department of Pharmacy, we certainly thought about what we could be doing to conserve the use of PPE in environments like our IV room operations. As far as capacity, we knew that we needed to get ready for an influx of critically ill patients. And we really looked at our medical intensive care unit and what the utilization patterns were there, and kind of thinking about there being some type of multiplication of the number of MICU services that we would be managing here at the medical center. So kind of that multiplying factor of whatever our expansion of an ICU footprint would be. In parallel, obviously, the medical center was looking for ways to increase our number of ICU beds, being creative and thinking about step-down units, maybe not being step-down, but actually an ICU, acquiring ventilators so that we could support additional ICU capacity. And, in an academic medical center, we have the luxury of maybe a bit deeper bench from a medical staff perspective. So how is it that we could clinically support multiple MICU services in the event of a surge? The supply chain has been tricky and a little bit difficult to navigate, just because we know that every organization out there has many of the same plans in increasing capacity and increasing their inventory levels in anticipation of that added capacity and demand. So that's been difficult. We've had to be really dutiful in checking availability of inventory, working with our wholesaler, working with our GPO to just make sure that they understand what our anticipated needs are in hopes that they can prepare and be able to serve us. The other resources that we are managing and trying to be thoughtful about is the most important one, which is our employees. There's a lot of uncertainty as it relates to when the surge will hit, how big the surge will hit. Uncertainty creates anxiety, and our most valuable resource is at risk of fatigue. And so how is it that we can be smart, giving people the time to get their home life stabilized, and being ready when surge comes, that we're able to kind of staff up and respond to it. I think that the two resources that come to mind, it's really supply chain. That's been mission critical. for us to feel prepared. And so our GPO and our wholesaler have been helpful in that regard. The other is just the amount of technology that we have rapidly deployed. Our clinics, one of the first things that we did, when we thought about these three strategic priorities, one of those being social distancing, is we canceled hundreds of thousands of clinic appointments, elective surgeries, and all of these patients still need follow-up. And so we stood up telehealth in a matter of days, just amazing. We are looking at the technologies that we can use to reduce the number of times that we actually have to don personal protective equipment and enter a patient's room. As we think about having, 4 more rounding services for critical care, are there things that we could do remotely so that some of the team can be outside the room or even outside the unit while maybe a critical resource or two are actually donning PPE going in at the bedside. So that type of technology is being adopted very rapidly. The other technology, I guess, would be the ability to actually perform our own tests. That became a real game changer. Initially we were sending tests off to the state, and the state lab had hoped for a 72-hour turnaround. Our lab miraculously was able to stand up our own internal testing within a couple of weeks, and now we get test results back in a matter of 10 to 12 hours. As soon as we get a test back and we can rule out, now all of a sudden we can change the precautions and reduce the amount of PPE that we're using in real time. And so that too has been incredibly valuable. Interestingly, one of the areas where we have collaborated across multiple campuses and actually multiple health systems is, of all the things, hand sanitizer. Many boards of pharmacy have come forward to say that they would allow a pharmacy the ability to compound their homemade hand sanitizer. As our friends in supply chain have struggled with making that product available to a medical center, they've turned to us. And that has led us to turn to chemical facilities, even distilleries. Interesting, relationships across industries of how we can uniquely collaborate and respond to a shortage. Drug sharing across campuses is, I would guess, is largely within a health system itself. But in a city like Boston, we have 6 academic medical centers, within a couple of mile radius of each other. Those types of relationships are there in every day of the year. There are some early conversations and maybe some just general rules of engagement of how we can work together.